So the biggest risk factor for having a premature baby is a history of a preterm baby. So that group of patients is our largest sort of risk marker. Unfortunately, after 30 years of studying prematurity, we're not great at identifying those pregnancies without a history of preterm delivery that are likely to deliver preterm. Certainly, patients with histories of uterine surgery, history of cervical surgery, patients with birth defects that cause increased amniotic fluid volume, patients with multiples that have uterine overdistension. Those are all things that we know predisposed to having a preterm delivery. But a lot of the patients that present with premature rupture of membranes at say 26 weeks or preterm labor at say 26 weeks didn't actually have any specific risk factors that we identified. On the close horizon, there are a number of technologies that are going to improve our ability to identify in that low risk population those patients that are actually likely to deliver prematurely, and that'll be a game changer. Right now we've improved cervical surveillance, we've improved some of our diagnostic tools and sort of algorithms to better identify patients at risk for preterm delivery, or to pick them up earlier in that process that leads to preterm delivery and hopefully push that preterm delivery out a few more weeks. So that's a benefit. We have technologies after delivery. We administer steroids to babies, to moms at risk for having a preterm delivery, and that dramatically improves postnatal outcomes for the babies. So there's lots of things we're doing that are improving outcomes. We're still not great at determining which of those patients is the one that's likely to deliver prematurely.